Now, let's review the various cardiac dysrhythmias, beginning with the single most important tool you'll need to identify them. An electrocardiogram, called an ECG or an EKG, is a tool for diagnosing abnormalities in the origin and conduction of electrical impulses. It also provides diagnostic clues to various cardiac disorders, such as myocardial infarction, reveals the effects of some electrolyte imbalances, and assesses the effects of cardiotonic drug therapy. When clients present with cardiac symptoms, an EKG is done first as a standard screening procedure. Electrocardiography creates a set of printed tracings, one for each lead, that reflect the client's cardiac electrical activity. ECG graph paper is divided into large and small squares. Each large square contains 25 small squares. The horizontal squares represent time, and the vertical squares represent the voltage of the electrical impulses. The small squares each represent 0.04 seconds, so moving horizontally, one large square equals 0.20 seconds. Small marks across the top of the ECG paper measure 3-second intervals. These are useful for quick estimations of cardiac rate. Moving vertically, each small square represents 1 millimeter, and each large square represents 5 millimeters of voltage. In reality, voltage is measured in millivolts, with 1 millivolt represented by 10 millimeters on an ECG tracing. In clinical practice, however, waveforms are described as having, for example, 3 millimeters of height or depth. Interpretation of an ECG strip requires first that you recognize normal cardiac electrical activity. Let's look at a normal rhythm strip. The ECG records upwards or positive and downward or negative deflections from a baseline, called the isoelectric line. One cardiac cycle encompasses contraction or depolarization and relaxation or repolarization of the atria and the ventricles. The first event in the cardiac cycle is contraction of the atria, called atrial depolarization. It is represented by a small, rounded, upward deflection known as a P wave, which indicates atrial muscle depolarization. The next ECG feature is the QRS complex. The Q wave dips below the isoelectric line. It is followed by a sharp upward deflection, the R wave, and the sharp downward deflection called the S wave. The QRS complex represents ventricular contraction or depolarization. Ventricular repolarization is represented by a rounded T wave. Note that you do not actually see atrial repolarization because it is obscured by the QRS complex. In addition to the deflections, measurements of time required for impulses to travel throughout the heart are important. You can measure time by counting small squares and multiplying the number by 0.04 seconds. The distance between the beginning of the P wave and the beginning of the Q wave is the PR interval. A normal PR interval is 0.12 to 0.20 seconds, or 3 to 5 small squares. This interval represents the time it takes for the impulse to travel from the atria through the AV node to the ventricles. The QRS complex is measured from the downward deflection of the Q wave to the return of the S wave to the isoelectric line. It normally is less than 0.12 seconds, or 3 small squares. The ST segment is normally flat on the isoelectric line. It represents the time between ventricular contraction, remember that's depolarization, and ventricular repolarization. Ventricular systole, which spans both depolarization and repolarization of the ventricles, is represented by the QT interval, which is measured from the beginning of the Q wave to the end of the T wave. The QT segment normally is 0.36 to 0.44 seconds, or 9 to 11 small squares. To interpret a lead 2 ECG strip, follow these steps. First, calculate the cardiac rate, that is, the number of cardiac cycles in 1 minute. Count the number of R waves in a 6-second interval and multiply that by 10. A more accurate method is to divide 1500, the number of small squares in a minute, by the number of small squares between 2 R waves. Next, Assess whether the rhythm is regular by using calipers to compare the spaces between R waves. Now determine if a P wave precedes every QRS, if they look alike in shape, and if they appear at regular intervals. Then, measure the PR interval to see if impulses are conducted through the AV node at a normal rate, which is 0.12 to 0.20 seconds. Now, measure the QRS complex to see if impulses are conducted through the ventricles at a normal rate, which is less than 0.12 seconds. Then, determine whether T waves follow every QRS complex and whether they all look alike. A tracing that is normal in all these aspects reflects normal sinus rhythm. On our example, these components are normal and the rate is between 60 and 100, so this is normal sinus rhythm. Continuous cardiac monitoring is done for clients who are at risk for dysrhythmias. Dysrhythmias are abnormalities in the heart rhythm caused by abnormalities in the conduction system. What are some risk factors for dysrhythmias? Cardiovascular disease, chronic renal failure, hepatic or lung disease, pericarditis, drug use or abuse, shock, electrolyte disturbances, fear or anxiety, fever, pain, hypoxia, and infection. Prompt detection of dysrhythmias is important because many of them result in decreased cardiac output or increase the workload of the heart. Here's what can happen to the heart's rhythm: bradycardia, tachycardia, nodal block, premature beats, flutter, and fibrillation. Some dysrhythmias are relatively harmless, but require treatment because they can progress to more serious dysrhythmias. All nurses should be able to identify common dysrhythmias using a lead-2 ECG strip. Dysrhythmias are classified by the location of the conduction abnormality. They may originate in the atria, the AV node, or the ventricles. Atrial dysrhythmias include sinus dysrhythmia or arrhythmia, sinus tachycardia, sinus bradycardia, sinus arrest, asystole, atrial fibrillation, atrial flutter, and premature atrial contractions. We'll go through examples of each of these, starting with sinus dysrhythmia.
Sinus dysrhythmia. Rate, normal. Rhythm, slightly irregular. P wave, slight variation. PR interval, normal. QRS, normal. T wave, normal.
You can see that the only abnormality in this strip is a slight change in the rhythm. The significance? Typically, the changes coincide with respirations. This rhythm is clinically insignificant and no intervention is needed.
Sinus tachycardia. Rate, more than 100 beats per minute. Rhythm, regular. P wave, normal when visible. Not always visible with very rapid rate. PR interval, normal. QRS, normal. T wave, normal.
Note that the only abnormality is a rapid rate. It can be caused by anything that increases the metabolic rate or cardiac demands, such as fever, stress, dehydration, or exercise. The significance? Sustained tachycardia increases the cardiac workload and could lead to heart failure in some clients. The treatment? Beta-adrenergic blocking agents might be prescribed, and the underlying cause must be corrected.
Sinus bradycardia. Rate, less than 60. Rhythm, regular. P wave, normal. PR interval, normal. QRS, normal. T wave, normal.
The only abnormality is a slow rate. The significance? Excessive slowing will reduce cardiac output, causing dizziness, orthostatic hypotension, dyspnea, and disorientation. The treatment? Treat the underlying cause. Atropine will increase the rate if indicated. The normal dose is 0.5 milligrams to